Hello, this video is going to be a brief lecture on the respiratory tract and infections that we associate, common infections that we associate with the respiratory system. So we'll go ahead and get started on this. The respiratory tract is really divided into two separate systems that we think of. The upper URI infections are related to the upper respiratory tract infections, and then lower respiratory tract infections. And you can see the anatomy that's associated with the upper. It's essentially structures from the larynx up, or the neck up, and then the lower respiratory tract is going to be from that same area below, so inferior. The trachea, the bronchi that first break off, the primary bronchi are where the trachea first divides to the right and left, the secondary bronchi, tertiary, and then to the smaller structures called bronchioles, and eventually even at the alveolar level, which are the microscopic air sacs where all of the exchanges are occurring. So you would tend to think that upper respiratory tract infections are typically more easily managed and milder, and that is usually the case, except for this one with the epiglottis. The epiglottis is this structure. It's I don't know if you can see it, it's tiny here, but it's this cartilage flap that covers the trachea. So when you drink water and fluids and eat food, the trachea is blocked off so that you will not choke. This flap of tissue, if it becomes inflamed, which we would call epiglottitis, this actually is a life-threatening illness. And it is one that we see when people have not been immunized with the Haemophilus influenza serotype B vaccine. So it's very specific that Haemophilus influenza serotype B is the one that usually, almost predominantly, causes epiglottitis. Again, one of the upper respiratory tract infections that we do consider life-threatening and an emergency kind of situation. Pharyngitis, inflammation of the throat, is something that can be, annoying, but is usually not going to be a life-threatening event. Upper respiratory infections like rhinoviruses and adenoviruses that cause the common cold, these again are going to be an inconvenience, but not something that have any sort of significant types of mortality rates associated with them. Laryngitis, the same type of thing. Now let's take a look at the anatomy. I know that you all have most of you have had anatomy and physiology, but it certainly warrants reviewing some of the slides that are pertaining to this and all of the built-in mechanisms we have to protect us. We have an entire antibody class of IgA antibodies. We have antimicrobial proteins that are being produced. We have cilia that act as an up escalator. We have nasal hair that traps debris and pollutants so that they are less likely to cause reactive airway disease. So mucus is something that's good, not bad, but of course we don't want to have too much of that. These are all things that are protective, the white blood cells, etc. But let's take a look at things that actually we do commonly encounter as causing some illness. Obviously, these areas are colonized with normal microbes, normal biota, part of our microbiomes that we've talked about at a lot at this particular point in time. But we do understand that there are some things that can become opportunistic pathogens. So they should be in very, very low numbers. Some of these things that are listed here certainly can become opportunistic pathogens, but not if our normal flora is doing what it's supposed to be doing and competing with these and keeping us actually healthy. The lower respiratory tract we tend to think of as not having as many microorganisms, but certainly sometimes they can be found there. The ones that cause serious disease, the names of these bacteria should be kind of all familiar to you at this point. We've mentioned them quite often. Streptococcus pyogenes is that group A strep that we know is common cause of what people call strep throat. Again, Haemophilus influenza, especially serotype B. This is one that can cause upper and lower respiratory infections, that serious disease with pneumonia, Streptococcus pneumonia. We have immunizations against these two now. And we also have immunizations against Neisseria meningitidis, the meningococcal vaccine. All of these have been, we have seen decreases in the developed countries of people who have been immunized. So we've seen those numbers go down. Immunizations work, they save lives. So, but all of these should seem familiar, and I've asked you to keep your etiologies of diseases, your handout, your study guide out as we go through this, because you will be able to mark these down. Smokers and non-smokers have different normal microbiomes, and this is what makes smokers so much more at risk for chronic obstructive pulmonary diseases. It's very important to understand that as well. Pharyngitis, which is simply would mean inflammation of the throat. That's what that would mean. And in this particular picture, you can see these white, what are referred to as exudates. These white exudates are simply pus pockets. That's what they're called. And so this, you can also see how red the tonsils are here, and the back of the throat is very, very red. So these are the areas that would potentially be tested to rule out Streptococcus pyogenes. So it's not always Streptococcus pyogenes. Oftentimes viruses can cause the same type of erythema, which is the redness back here. Viruses are very much responsible for this as well, but ruling out strep throat would be an important thing to do with a direct serology test or a throat swab, and then backing that up with a culture if it's negative, making sure that they back that up. Streptococcus pyogenes, again, though it's not the most common cause, most sore throats are from viruses, allergies, and then viruses. But the reason that we really do need to treat it is because of the complications. That's why someone's getting treated that has a positive strep test. It's not really to help them with their sore throat, though that's maybe what they're thinking. It's really to help with potential secondary or sequelae things that can happen. So scarlet fever is a huge one, and this can give a huge concern, I should say, that can happen. And this will typically give a sandpaper kind of rash all throughout the body. It's associated with a high fever as well. The toxin, if this goes untreated, the mortality rate can be significantly high. Another sequelae can be rheumatic fever. This is because of the immune system actually cross-reacting with the proteins and then damaging the heart muscle. So people, again, when people get treated for strep throat, it really isn't to treat their sore throat. They would get over that. It's to prevent the occurrences that can happen sometimes, but not commonly, but they can happen, called scarlet fever and rheumatic fever. That's an important thing to understand. Sometimes we're treating not really what's going on right then, but we're treating to prevent worse things from happening. So again, the virulence is a result of two different things. I don't get into the detail about the cellular and molecular toxicities, but these are the different types of reasons that this particular bacterium can be so very dangerous and what it's doing in the body. So these streptolysins, these different types of streptolysins that can actually lyse your red blood cells. And there's also this erythrogenic toxin that is responsible for that rash and fever. So again, these signs and symptoms can lead us to think that maybe Streptococcus is responsible, so a test needs to be done. Direct test as well as follow-up cultures, and then treatment to make sure that we can prevent some of the more serious types of situations. On the culture, you can see the microbes. This bacterial culture is showing where it's lysing the sheep blood agar, and it's very easy, really, to diagnose. Typically, penicillin is the drug of choice. We have seen little pockets of epidemics, you could say, in certain geographic locations where we've seen a resistance to the basic penicillin and or cephalexin with people who have penicillin allergies. But for the most part, it's fairly easy to treat, and it should be treated fairly early. Fusobacterium necrophorum, I'm not sure that that's on your etiology list, but if it is, here you can see it as well. This is actually something that in the last recent time, I know you think last 2 decades isn't so recent, but it actually, we're seeing more of a common cause in young adults. This can be part of the normal microbiome, but when it gets an overgrowth of this, it can actually manifest itself, leading to very serious complications, this Lemire syndrome, which is going to be phlebitis of that internal jugular veins, and it can then lead to sepsis. So obviously this is not that common, but it is something that when you have someone who has a strep throat where there's a lot of swelling, and it's just a little bit more serious signs and symptoms that you would see, and you want to be thinking about this one. Again, fairly easy to treat, you know, with some penicillins, but it's not, it just needs to be addressed and certainly needs to be treated. So the common cold, there are over 200 different viruses, and of course this is due to viruses, not bacteria, so viruses. There are many different ones. Respiratory syncytial virus, which we know we're very concerned about with infants. It's the #1 cause of hospitalization of infants. Adenoviruses, coronaviruses. These are respiratory borne, and even through indirect contact like doorknobs, inanimate surfaces. So we understand that, you know, these run their course typically. What we don't want to see is someone start with this and then end up getting sicker with a secondary bacterial infection. This is why we worry so much about RSV in children. This we do have to be careful of aspiration pneumonia that would then lead to a secondary bacterial pneumonia that gets on top of it. But for the most part, common colds, you treat the signs and symptoms, they go away in about 7 days. Any excessive treatment, they'd still go away in about a week. So in other words, there's really, you know, really no treatment. Sinusitis is inflammation of those sinus cavities in those cranial bones, the frontal bone, the ethmoid, the sphenoid, and the maxillary bones have sinus cavities, and these cavities should be filled with air. If for some reason, due to allergies and or viruses like cold viruses, these cavities get fluid in them, then sometimes you can get secondary bacterial infections as well. It can be more difficult to deal with. So if they're lingering or if they're causing a lot of discomfort with signs and symptoms, then typically it's going to have to be a broad spectrum antibiotic because there's usually more than one bacteria involved, and or antifungals, because again, all of the normal flora that's there, it will take the opportunity if there's fluid in those sinus cavities to cause trouble. Most of the time, though, sinusitis is from allergies that have caused fluids to build up in the cavities and or viruses. So the best thing to do is to try to take decongestants, try to dry out those sinuses, sometimes using the neti pots. These are the best treatments, hopefully preventing any secondary types of things that can require much more invasive kinds of treatments. So moving along, otitis media is going to be an ear infection. So acute means that the signs and symptoms come on quickly, and they really do sometimes, especially in children, and it's a middle ear infection. That middle ear should be filled with air. So that middle ear cavity should be filled with air. That's where those 3 tiny little bones are that we understand, the malleus, the incus, and the stapes. The malleus, the incus, and the stapes. This should be filled with air. There's a drain tube, the eustachian tube, that's draining any fluid that may accumulate, but the problem comes in is when there's swelling, because of infection. Again, allergies and viruses are the most common cause of otitis media, but then that extra fluid, because of those allergies and viruses, can sometimes set someone up for having bacterial and or other infections on top of that. So keeping this area free of fluid is really important. So taking anti-allergy medication and or decongestants when there are viruses involved are the best step. If there's any sort of concern that there might be some bacterial agent involved, then they will give antibiotics. This eustachian tube drains into the back of the throat behind the nose. It's called the nasopharynx. And because there is this connection to the nasopharynx and the ear, sometimes microorganisms will get into this nasal area and even move up through the lacrimal duct to the eyes. So if someone has conjunctivitis, which is inflammation of that membrane in the eyes, they very much need to also check their ears to make sure that this membrane, this eardrum, this tympanic membrane, which is what we call an eardrum, is not looking like it is bulging or that there may be fluid in this middle ear. Oftentimes conjunctivitis can go along with otitis media, so they both need to be checked. Pneumonia is our highlight disease, and this is defined as inflammatory condition of the lungs, so a lower respiratory infection of the lungs. There are many different causes for this. Most of the time it is viral. So that is actually, usually very good news, because you're going to treat the signs and symptoms for this. This is a serious lower respiratory disease, and you have to treat not just for the signs and symptoms of the virus, but prophylactically. All pneumonias will be given antibiotics because you do not want a secondary bacterial infection coming in causing the pneumonia. The viral pneumonias often are self-limiting. They will resolve, but a bacterial pneumonia is deadly, much higher mortality rate. So when someone has a viral pneumonia, which is usually viral, they will be given antibiotics always as a prophylactic, and this would be important to understand. Pneumonias can be deadly. They do have significant mortality rates, and this is a statistic telling you that children under 5 often die from pneumonia around the globe in developing countries where medicine is not so readily available to all, is one of the leading causes of death in children under 5. So again, this is can be a lot of different microorganisms involved. Usually starts off with something viral and then ends up being something more serious. These are some of the microorganisms we usually encounter. So these are going to be all bacterial, but the walking pneumonia is what we call mycoplasma pneumonia. Y'all will see these on your etiologies list. But histoplasma is a fungus. So there can sometimes, on rare occasions, in people who are immunocompromised or people who have gotten a huge inoculating or infectious dose of the fungus, they can be susceptible to this. So pneumonia can be also secondary to influenza, which is why when people have influenza, it can have such a high mortality rate in the young and the old, and why we try to prevent influenza by giving immunizations, because we do know influenza can have a significant mortality rate. And it has that mortality rate because in some people it will progress to pneumonia. So again, why immunizations save lives. The SARS, severe acute respiratory syndrome, COVID-2, CV2, which is recognized as this etiology of the pandemic that we, started in really 2019 and 2020. But anyway, by 2020, it was really identified as a novel coronavirus too. We had seen coronavirus SARS-CoV-1 that had a 30% mortality rate about 2 decades ago. So much has been known about coronaviruses for decades. And this one that's currently causing a pandemic that will become an endemic, we had seen the first one, and we had seen MERS as well, that had a 35 to 40% mortality rate, but luckily was quarantined down. MERS, Middle Eastern Severe Respiratory Coronavirus, more than a decade ago. So I think that you guys can look, and many people we've talked about the CV2 is what we refer to it as. And we've had a lot of information about that, so I'll go ahead and go through that. Please feel free to go back through these PowerPoints and look at what I've highlighted for you. And we understand that the best prevention is a vaccine. That's the best prevention. But then we also have mitigating things that we can do. We can keep distance, we can wear masks, we can do making sure that we're hand washing being the #1 way to help to prevent the spread of disease. And so all of these things are important for that. Community-acquired pneumonia is caused from Streptococcus pneumoniae. This is a bacterium. And again, some of the numbers of this we are seeing going down because of the Prevnar vaccines that we have. And so these are recommended now as a protocol for the senior citizens, but also it's been included now in our pediatric protocol. So we're definitely seeing the numbers of this go down in developed countries where immunizations are working. But the problem comes in areas, pockets of areas where people don't get immunized or don't have access to proper health care and preventative health care. Some of the factors that we know put people at risk is age, the season, underlying illnesses like diabetes mellitus, and then chronic drug abuse is also going to put someone at risk. Another bacteria that can cause community-acquired isolated peaks are Legionella pneumophila. This again is a bacteria that can, depending on the infectious dose that the person inhales, this can affect almost anyone. It is persistent in natural habitats, so we know that it is in tap water, it is in air ventilation ducts, it is in all of those areas, and so we look for that. Atypical pneumonia or walking pneumonia, as I said before, Mycoplasma pneumoniae, and chlamydia is another one, pneumophila. Chlamydia pneumophila is another one that is on your list that you can take a look at. Hantavirus is sometimes listed as an emerging virus of concern, but actually it's been around for a really long time. It usually requires very arid areas for this to proliferate, so it can be airborne in dust, so very dusty, arid regions, and it is from rodents that have, there's urine or feces or saliva from infected rodents. So, the last outbreak I think was from people who were hiking and they'd gotten into a very remote little cabin that they dusted the floors so that they could sleep in, but dusting those floors really got this is where they know that these people, these hikers who were in very good shape, young, healthy adults, ended up getting this particular virus. Again, a fungus. Now we're talking about fungi, so you can go to that part of your etiologies chart and think about histoplasma. Histoplasma is something that we know you get from bird and bat droppings. So sometimes people who are spelunkers, spelunking is caving, right? People who like to go into caves. I don't understand that, but some people like that, exploring caves. We've seen people who have been exposed to bat droppings in caves. We've seen people who have birds and chickens and who are exposed to a lot of pigeon droppings. having this particular fungal pneumonia. Again, it would require, in a healthy person, it would require huge infectious dose being inhaled, but in immunocompromised people, it doesn't require that much, and so that's who we typically see it in. Pneumocystis jirovecii, or carinii, sometimes called, it's still called Pneumocystis carinii, and you will also hear it as jirovecii. This is only seen, really, Pneumocystis pneumonia, in immunocompromised patients. So it is often the one that we see as the last thing that someone who has AIDS has. And it is an opportunistic infection, and it is a serious infection that has a high mortality rate in these patients that have now gotten into that are HIV positive, have now gone into full-blown AIDS. And this sometimes is the last infection that they have because of the mortality rate being so high with this. So viral pneumonias are generally mild, they're generally self-limiting, but they are all going to be treated with antibiotics. Even though we know antibiotics don't work against the virus, we're treating them with antibiotics to prevent a secondary bacterial infection. I know I say that over and over, but it warrants it. Hospital or healthcare associated pneumonia. This is not that common, but it is very serious. You can see the mortality rates are high, especially if someone has picked up these pneumonias in the hospital. They're in the hospital, so they're already immunocompromised. They're already battling something else. And then because of, ventilation, being trached, or some sort of reason that they have now picked up a secondary pneumonia, the most frequent causes are going to be bacterial, and sometimes it's polymicrobial, meaning more than one of them. And again, even with treatment, incredibly high mortality rate associated with them. So you can see that treatment's got to be aggressive. It's going to have to be aggressive for these. Influenza, which is something that we deal with on an annual basis, we see certainly during the seasonal. It's actually there all year, but during seasonal situations where people are more indoors and winter and fall winter months, then it becomes more widespread. We understand that these are pandemics that are ongoing, aren't they? And some strains can have a higher mortality rate than others. So it's changing and evolving all the time. Some of the signs and symptoms, we call these flu-like symptoms, don't we? Headaches, chills, dry cough, body aches, fever. Certainly flu-like symptoms you've heard of. These viruses, the influenza virus is rapidly evolving. Again, this is why we have to still have annual immunizations to help to prevent the intensity of the disease. Doesn't always immunizations for everything. Does immunizations for some diseases prevent the disease? But for some things like influenza, it doesn't always prevent the disease, but it can prevent the severity of the disease, and it can help to prevent the spread of disease. So more than one reason for immunizations, right? So I think we all kind of know that by now. And they are rapidly evolving, so again, why you need to do, there are these antigenic drifts and antigenic shifts that occur, and this is why it's more, we do annual immunizations. It is probably in the very near future, I won't guess how near, that there may, with the science that's happening now at such a pace, and with the better immunizations that we are developing, then immunologists are developing, that it is likely that there might be soon an immunization that you can do that would cover many of the different potential antigenic drifts and or shifts. So the difference in the shift is that this is when a shift is going to happen when multiple species, so animal species virus mixes with the human virus, and then that combination becomes a much more virulent strain. So, so that's how that actually works. And when we think about what is going on, this virus invades the human host cells, causing a shedding of the cells, which then causes the inflammatory response to sometimes over-respond. And that cytokine storm that happens can then actually end up causing as many or more of the consequences than the virus actually itself within the host. So, you know, there's significant deaths annually to influenza when we think about this. This is just in the United States, but, you know, where, again, not to harp on coronavirus and the pandemic that's going on with this particular coronavirus strain, but many people who didn't understand numbers would say things like, oh, coronavirus is just another influenza. It is not another influenza. We have lost almost, just in our country, almost 1 million people at this time lost them to coronavirus. Those are the ones that have been counted. That does not include the morbidity rate of the people who have long-term COVID that have complications they will deal with and have been dealing with for months and even now over a year. So that's not even including that, and that is just in our country. So again, where influenza typically affects very young, very old, the coronavirus, the particular one that we're dealing with now, there are many coronaviruses, but the one that we're dealing with now in the pandemic has really been like a Russian roulette. Certainly the elderly have been the most at risk, but there have been some young adults that for no defined reason, like I said, Russian roulette has attacked their hearts, their GI systems, their blood-brain barriers. So, you know, it's, again, very different. The current coronavirus that's causing our pandemic, very different from the typical influenzas, not the same at all. So, you know, we can actually diagnose through direct serology testing, is how that diagnosis typically is going to occur. And again, there are new vaccine prospects, and we are looking forward to that. So maybe the annual vaccines can be replaced by just taking a one-time type of thing, and then maybe boosters later on. So influenza, just like any viruses, the treatment has to occur early. Antiviral medications are to sort of lessen, that's their best thing that they can offer by interfering with those steps like absorption, penetration, that encoding, the synthesis that happens inside the cells has to be done early. And really therapeutic indexes can sometimes be kind of low, and the effectiveness can be kind of low unless the treatments are done incredibly early. Pertussis, whooping cough. This is from a bacterial cause, Bordetella pertussis. This we don't see as frequently in developed countries now because of the vaccine, the DPT, diphtheria, pertussis, tetanus, that trivalent vaccine that's part of the pediatric protocol. This, again, we typically only see in people who have not been immunized, and it does have a fairly significant mortality rate, so we want to prevent this in any way that we can. The vaccine does not last forever, so this is why people who are of childbearing age, if they decide to procreate and get pregnant, they are often advised to, before their infant comes, they're advised to get a booster so that they won't expose their infant to this before the infant can get immunized. And also even grandparents and child care providers are re-immunized to get a vaccine booster for this, because the vaccine does not last forever and we need to protect our children. So again, getting vaccines isn't always just about protecting yourself, it's about protecting those around you. Respiratory syncytial virus, #1 cause of hospitalizations of infants around the world. And it becomes very dangerous for infants because of all of the cells that are being exfoliated in the upper respiratory tract and the fluids. and infants can't cough. I mean, they don't cough the way they should. They can't blow their noses. So all that fluid, they are aspirated. They have potential of aspirating. And then that leads to pneumonia. And it is a very, very much a high risk for children. Tuberculosis is caused from a bacterium, Mycobacterium. There are a couple of different species. One of them is tuberculosis, Mycobacterium tuberculosis. There's also the Mycobacterium avium intracellulare complex. It is referred to sometimes as MAC, M-A-C. Tuberculosis has been around for as long as there's been written history. We've read about people with signs and symptoms that we know were most likely from tuberculosis. So it is a serious threat. You can certainly see how common it is and how many people are infected with this. As far as the worldwide population goes, it is very, very common. Most are in the lungs, but you know, this can be a reactive primary disease, a secondary, and then a disseminated extra outside of the lung infection. So anyway, it has a significant mortality rate if left untreated. There is a vaccine for this that the United States has not taken on, and there was an interruption there, sorry. So getting back to this primary tuberculosis, tubercles form in the lungs, and these tubercles get walled off by the immune system. And then at a later time, they can actually break through, and there can be, as we said, a secondary type of reactivation or reinfection. So in our country, we don't use the immunization because the reason that we don't, because it sounds like, well, why don't we just immunize? In other developed, all other developed countries do use the immunization and people get immunized. But in our country, we don't, because we are still using a PPD test for diagnosis. So if people were immunized, then we couldn't use that test to screen for diagnosis. So it's probably going to be sooner than later that public policy changes on that, and that it will be recommended that that people, especially healthcare providers who are being exposed to these people, get the immunization. But right now we're using that screening test again to see. It's an indirect screening test to look for antibodies to see if someone has become infected or been exposed to tuberculosis. So you can look through that and read more about that. So if someone has active TB in a clinical setting, they're going to be in isolation until they have 3 negative tests from pathology, and then they can come out of isolation. But it's going to take 3 negative sputum tests before they are brought out. And it is important that health providers actually are very aware of still that tuberculosis is a very common disease. And if there is any sort of thought that a patient might have tuberculosis until it's ruled out, they should definitely be put in respiratory, negative pressure rooms and be treated as a patient in isolation is treated. So, again, we have Mycobacterium tuberculosis is one of the species, and we also have Mycobacterium avium intracellulare is the name of that, and again, this is sometimes called MAC, and these are things that we are concerned about as far as epidemiology goes. So I have lots of slides on that. So this is talking about the tuberculosis screening and prevention, and then treatment. If someone has a positive PPD test and or blood test for this, then they're going to have prophylactic treatment, and that treatment is usually 6 months minimum. So I know this might say 2, but usually it's 6 months minimum depending on the case, and that treatment has a low therapeutic index, which means that it is pretty toxic to the patient in the liver, so they're going to have routine, like every few weeks, 4 to 6 weeks liver function tests done because of the treatments, but it is absolutely going to be necessary to do that. So there are a couple of resistant strains now. There's one that is resistant to everything, and we have nothing that we can treat it with. There's a strain that is resistant to everything, and the mortality is usually within months of diagnosis. So again, at the end of these chapters, at the end of these organ systems, are these nice little synopsis of the infectious diseases that are commonly encountered in the organ system. So this one for the respiratory system, I think they do a good job of this. And best wishes to you all. See you on the next go round. Okay.